Okay, guys, we can start our afternoon report. Neha, go ahead.
All right, good afternoon, everyone. Welcome to today's afternoon report. So the chief complaint for today's afternoon report is neck pain for one day. So we have a 49-year-old female with a past medical history of depression, anxiety, and mitral valve prolapse, who presents to the ED with left-sided neck pain for one day. The neck pain is sharp and shooting, radiating to the left arm, which she says began after she slept on the left side and worsens with stretching. She tried using heating pads and Motrin with minimal relief and denies any trauma, heavy lifting, IV drug use, or cancer history. Do you guys have any questions at this point?
Anything you want to ask to this patient when she's coming to the ED? They're asking if she had any weakness.
Nope, no weakness.
Any fever?
No fever.
No chills?
Nope,
Okay. Any numbness or tingling?
none.
Any chest pain?
No,
Okay. Any dyspnea or shortness of breath? Yep.
nope,
Similar prior symptoms?
no similar symptoms in the past.
Okay. Tell us more.
All right. Going into a longitudinal history, as I mentioned, she has a past medical history of depression, anxiety, and MVP. In medication history, she just takes Klonopin for her anxiety, 0.5 BID, and venlafaxine 150 daily at night for her depression. Family history, mother had a history of breast cancer, hyperlipidemia, hypertension. Father was hypertensive, both are alive. And social history, she is from upstate New York, currently residing in an apartment in New York, in the city. She is a non-smoker, no known IV drug use. Initially, she said that she is an occasional drinker, but eventually on asking further, she said that she drinks about 1 pint of hard liquor daily since the past 5 years. As for her job, she has an administrative job at and works for the FBI. Review of system-wise, positive finding, we just have left-sided neck pain, which is radiating to the left arm. Negative, as you all asked the questions, she has no fever, chills, night sweats, weight loss, tingling, numbness, no motor weakness, bowel or bladder incontinence, chest pain, shortness of breath, or abdominal pain. On physical examination, her vitals were pretty stable. Blood pressure was 127/77, pulse was 99, afebrile, respiratory rate of 77, saturating at 99% on room air. Constitutional-wise, she was in no acute distress. She's an obese lady. Her weight is about 260 pounds. Hint examination-wise, head is atraumatic, eye pupils are equal and reactive to light, no cervical lymphadenopathy, respiratory system-wise, pulmonary effects were normal, chest was clear to auscultation bilaterally, cardiovascular examination-wise, nothing significant, normal rate and rhythm, no murmurs. Abdominal examination was soft, non-tender, non-distended with bowel sounds present. And on musculoskeletal examination, it was tended to palpate on the left side of the neck with limited range of movement of the neck to the left due to pain, and normal active and passive range of movements of her left upper extremity. Neuroexamination wise, cranial nerve 1 to 12 intact, no focal neurodeficits, ANO times 3, and motor strength was 5/5 in all limbs. All right. So what do you think the workup was done in the ED, and what was the possible course of action for this person who presents to the ED?
Would you guys admit this patient? Let's say you're in the ED team. I agree with Kruti was saying now. Well, I mean, yeah, like, right, she's like middle age. She's just having some neck pain, and you guys asked all the right questions. You wanted to see if she had, weakness and every other like type of, chest pain, other symptoms that might make you think about something different. But right now it looks like everything is normal. Her physical exam looks not too, dramatic, and she has normal, she has normal vitals. X-ray, why would you guys get an X-ray on this patient? You need to tell me because you wrote in the chat. Look for infection. Okay. So we can talk about it, but I think right now the patient technically, any fracture, yeah, okay, but we need to look at our patient, okay? So right now we have a middle-aged patient. She's not taking medications that would make us think about fracture that we know of, right? She's not taking steroids. She doesn't have history of trauma, even though we actually forgot to ask Neha if she had any trauma. So right now, technically, she's not very high risk for a lot of anything. And a lot of the questions you asked, which were good questions, she was negative. She didn't have any, weakness, any chest pain, anything that make you think, okay, I need to do a workup. Okay, she's from the FBI, that's true. But I mean, we should trust our patient when we're talking to them, unless we think something is off. So I think right now, what would you guys do? Would you discharge the patient with some pain, like Catherine was saying, or would you say, no, I need to do more workup? Why do you want to do an EKG? Okay, so I think personally that probably I would have discharged this patient with some pain control, because right now she doesn't have any flags for me. But I don't know, Neha, tell us what happened.
Okay, so so this patient actually felt better in the ED after pain control, and pain was thought to be musculoskeletal since she clearly said that she slept on her side. No labs and imaging were done during this visit, and she was actually discharged home with lidocaine patches, Motrin, and Tylenol. Okay, so going forward, now the same patient now comes back to the ED after 2 days on February 3rd, complaining of persistent neck pain. But now the neck pain is associated with some tingling sensation, which is new, which was not there before. She's also complaining of left-sided chest pain, subjective fever, and radiation of the pain to her right lower back. The left-sided chest pain gets worsened if she's raising her left arm. She tried using Tylenol and Valium at home with minimal symptom relief. She was also trying to use heating pads for the neck pain, and nothing helped her. Review of system-wise, now it is positive for neck pain radiating to the left arm with tingling sensation in the left arm, fever, right lower back pain, and chest pain. Negative system-wise, she still does not have any motor weakness or bowel or bladder incontinence, shortness of breath, palpitation, nausea, vomiting, chills, dysuria, hematuria, sore throat or rhinorrhea or headache.
Dr. Asori is asking if she had any dental procedures before.
No, she did not. So now this time that we did her vitals, her blood pressure was normal 115/63. She was tachycardic 206. She was febrile with a fever of 100.8. Respiratory rate slightly tachypneic to 22, saturating well at 98% on room air. Most of the physical findings were same, except for now in musculoskeletal. She now has the left paracervical tenderness, which was already there before, but she also has right paralumbar area tender to palpation, limited range of movement of the neck to the left, which was there before, with no overlying swelling, erythema, or warmth, and reproducible right lower back pain with ipsilateral and contralateral straight leg test. Neuroexamination still remains the same, no motor weakness at this point.
So I think before we show your blood work, so what do you guys think now? Did you change your mind?
Bad, sorry.
It's fine. Did you guys change your mind on what's happening to this patient? And I think all of it, what you guys said before, I mean, it makes sense, especially now because more things are happening. Would you admit this patient? Would you send the patient home? Okay, so you would do more workup and maybe admit her, see what's going on. And then I'm gonna just stop sharing your screen now for a second. And before we move on with the case, I really wanted to ask you guys, I don't know if it happened to you before, especially if you guys go to, let me see. If you guys do any type of Ryan Center or any outpatient situations, Has it happened to you that the patient comes with neck pain? That's their chief complaint. What do you guys think, and how do you guys kind of approach the patient? Like, what do you guys want to focus on when someone is coming with neck pain? Trauma. I like that. Yeah. And other symptoms, neurodeficit, perfect. So always you want to rule out things that are emergent that might need, workup, and then you focus on anything that can be, as Catherine was saying before, just pain management and reassess. Okay. So the way I look at it is just to have those big kind of like things together that kind of help me understand. The neck pain can come from musculoskeletal issues, and this is just a video to show you all that most of the muscles and tendons and ligaments are lateral and posterior. So that's why a lot of musculoskeletal pain will be posterior. And then of course you have the bones, which of course are posterior, it's the spine. The pain can be from neurological issues or radiculopathy, myelopathy when the nerves are involved, or it can be non-spinal. So that means that another disease is causing something that's causing pain in the neck, but it's not really coming from the muscles or from some issues that's musculoskeletal or from the spine itself. Okay, so that's like the big groups of neck pain. And then if we start from musculoskeletal pain, I put here just the most frequent one. And absolutely, like cervical strain is very, very frequent. Basically, it's just some type of strain of the muscles of the ligaments that can be caused by minor trauma. But also, let's think about our patient. She came in the first time, she said, I've been sleeping in a weird position, now I have neck pain. So that's classical cervical strain. Like it can be just a poor habit of the person that maybe sleeping weirdly, staying a lot of the times at the computer, and that's causing pain. So you just assess the patient, and you just have a clinical diagnosis, and we can just discharge a patient if it's in the ED, or in outpatient setting, you just give them some pain meds, some physical therapy, and that's it. And here it says, I don't know if you can see my pointer, but like provocative maneuvers, we will talk about them very quickly. It's just something you can do when you assess the patient to see if there's nerve involvement, okay? Another very frequent injury is the whiplash. And we study that in med school. It's like the classical car accident, there's acceleration, deceleration, and then you have a lot of extension and flexion of the neck. So a lot of the structure can be damaged. And you can have pain, you can have headache, you can have problems with your sleep, you can have a lot of issues associated with that. Discogenic pain and osteoarthritis, they're all the changes, the chronic changes that you can have in the cervical spine. So changes in your disc that can cause pain, or changes in your bones. So you can have, like here, it says here, like these spurs that can cause pain. And the discogenic pain or the osteoarthritis, if they're impinging on the nerves, then they can cause also radiculopathy. So that's why it says that the provocative maneuvers can be positive, it's variable. And then you can have cervical myofascial pain, which is like similar to fibromyalgia, where you have the trigger points and then you push on that point and that causes pain and pressure on the patient. So most of these things, you do not need a workup, okay? Then you can have, this is the trigger points. The radiculopathy type of pain, which is neurogenic. So anything that's impinging on the nerves, and usually it's either radiculopathy or myelopathy. What's the biggest difference? So radiculopathy, you are only affecting the nerves, and it's not showing here, there's a lag, but okay. So you're only affecting the nerves as they're coming out of the spine. So the problem will be on the upper extremities, and it's a dermatomal distribution depending on the nerves that you're affecting. And your provocative maneuvers will be positive. You don't need imaging even for this. You just diagnose the patient with your, clinical assessment. And then if you do an MRI, you will see that there's some nerve damage, but most of the times you don't need to do that. While myelopathy, the big issue here is that you don't only have the problem with the nerves, but there's something that's pushing down on the spinal cord. So the spinal cord has all the nerves that are coming down, right? They're going to the lower extremity, they're going to your pelvic organs, to your abdominal organs. So you start having not only the neck pain, but you have the weakness of your leg, you can have the gait imbalance, you can have hyperreflexia, you can have problem with the bladder and with the bowel. So that's something much more urgent, and you do need MRI to see what's happening in your spinal cord. And then finally, there's tons of non-spinal causes of neck pain. And as you guys were asking for, chest pain and other symptoms, because you can have, CAD causing neck pain, you can have infections causing neck pain, you can have cancer, you can have headaches. So there's a bunch of stuff. But most of the times in this case, your history, your symptoms from the patient will give you a clue that this is not just, a musculoskeletal neck pain, okay? So let's say that we are seeing the patient right now. What do we do? One of you guys said trauma. So trauma is always the first step. Let's say that you've seen the patient in the ED or in the clinic, wherever you are. So you always want to ask if there's any trauma, minor or major, because your triaging will change. And usually if the patient is older or has rheumatoid arthritis, you have kind of a lower threshold to consider a trauma important, because these patients are at risk for osteoporosis and also for atlantoaxial instability. So you want to consider that you need imaging in these patients. So if there is trauma, then your answer is go to the ED, mobilize the spine, imaging, and et cetera, et cetera. If there's no trauma, then you guys were asking the right questions. You want to see if there's any red flags, which is very similar to the red flags of the back pain, to see if that patient needs more workup. So that will be your second step during your interview with the patient. And these are the most important red flags. So anything that can make the patient a risk for infection, like if the patient had fever. So our patient, the first time she had nothing. So that's why we were like, okay, send her home. But next time she's coming back and now she's telling us that she has a fever. So that's, that's kind of like a red flag in our mind that this neck pain might not be only neck pain, okay? And then other things that can increase the risk of infection are IV drug abuse, any type of immunosuppression, like even using steroids. Steroids can also cause you a fracture. So that's also another red flag. Weight loss or this sort of cancer, because you can have other primary cancers or metastases here. And especially in your physical exam, if you're pushing a lot on the bones, on the spinal area, there's a lot of pain, that can be suspicious for cancer or for infection. And then other red flags are systemic symptoms. As we said before, chest pain, anterior neck pain, it's abnormal. We already saw that most of the structures are posterior. So an anterior neck pain might be something different that's not coming from the neck, maybe a carotid dissection, maybe an MI. And then, as we said before, anything that can cause spinal cord compression. So you have lower extremity symptoms, bladder dysfunction. This is very concerning. The patient probably has something that's compressing on the cord. So if any of this is positive when you're doing your interview with the patient, then you already know that you need more workup and maybe you need to admit the patient, okay? And the workup, of course, depends on what's your suspicion. But in general, these patients will need imaging. And most of the times, you actually trump the X-ray and you go directly to the MRI. And you usually do an MRI with contrast if you're suspecting an infection or you're suspecting a malignancy, because you want to see if there's anything that's attracting, that's taking that contrast. So that will be your first step. Let's say that everything else is negative. So no trauma, no red flags. Let's say that this is the first time that the patient is coming to the ED. Then you just focus more on the history and on the physical exam to try to see if it's a musculoskeletal issue, if there's a radiculopathy, or if sometimes you can have a headache that causes neck pain. So you just want to see what's causing the neck pain. And a lot of these things will be benign. So you have the time to kind of talk to the patient, talk through, and those patients don't need, imaging or to go to the ED. And then the history, we all know that. We will ask when the pain started, how strong it is. You want to see if that's affecting the daily activities, if that's very severe. And then we saw that already. So physical exam is important because you need to check for neurological also symptoms and signs. So you want to see if there's weakness, hyperreflexia. You check the upper extremity, but you check also the lower extremity. So you want to make sure there's nothing neurological that's abnormal. And then you can do provocative maneuvers that we were saying before, and I can show you this one. Super easy. And the provocative maneuvers are just to check for inflammation of the nerves. So you want to see if there's radiculopathy. One, like this is called cervical compression test, and basically you just want to kind of press on the patient to trigger that radiculopathy. Let's say that the patient tells you, sometimes I have tingling on their arm, but not right now. you can do the test in two different ways. You either have the patient like this with the head straight, or you ask the patient to bend the head towards the side that the neck is hurting. And then you push down, like they're showing the video, you push down on their head. And if that's causing the pain and triggering the radiculopathy, so the weakness, the tingling, whatever that is, you know the patient has a radiculopathy. If that's negative, most likely the patient does not have a radiculopathy. Okay, unless they're telling them that, unless they're telling you that at rest they have already that type of pain. But if they don't have it at rest and you cannot trigger that pain, most likely they just have a problem in their neck without inflammation of the nerves. Okay, so we have done that on our patient. Let's say that she didn't tell us that she had a fever, and she tells us that she has, the tingling and numbness of the upper extremity, or we find positive maneuvers. Then we said, okay, this is cervical radiculopathy. There's something impinging on the nerves, like here. So it's not really impinging on the cord. It's just impinging. Like this is my okay. It's just impinging here. Like it can be an herniated disc. It can be some bony spurs. Can be wherever. This situation, you actually, that's it. You don't need to do anything else. You do just conservative management, and you might prescribe some NSAIDs for a short period of time. You can give them physical therapy referral, but then that's it. If the pain doesn't improve and after 6 weeks they still have a lot of pain, or the symptoms, the neurological symptoms are getting worse, or there's new ones, then that's when you want to do imaging, and you can do an X-ray of the cervical spine. You want to see if there's any fracture, anything that you haven't seen, or you can do an MRI. And in this situation, you don't need to do the contrast because you're not looking for an active infection or cancer. You just want to check the bony, the muscle, all these structures to see if there's anything that's causing the impingement. And then it's very similar. Let's say that the patient has nothing of this. So it's just neck pain, no red flags, nothing else, no radicular pain, no upper extremity involvement. Then it's probably just, a cervical strain, any of the musculoskeletal reasons that we looked in the beginning of the presentation, or it can be a benign thing like a headache that's referring the pain to the neck, okay? So the management is the same. It's conservative. You don't need to do anything. And then again, if the pain doesn't go away and it's very severe, or there's new neurological symptoms, then you do more workup and you do imaging. Okay, so that's like a quick way to kind of approach your neck pain when you are inpatient or outpatient. And I'm gonna stop sharing my screen. And I want to know now, you can share your screen. Yeah? What are you thinking of this patient now, after what we talked about and after what we saw from Neha's presentation? Are you worried about her or no? Would you do a workup? I think we said that we want to do a workup. Okay, so now tell us what happened.
Okay, so we did blood work on her, and this is what we found. Her white counts were not elevated. Hemoglobin was normal. Her platelet is 68,000 and MCV is 113. I looked up the chart before. Her platelet this is the first time that she was coming to Sinai, getting testing done. In 2011, her platelet count was normal at 220. Chemistry wise, her sodium was a little low at 127. Other than that, everything else looks pretty normal. We also got a VBG done, which shows a little lactate of 2.2. A UA was done, which was negative. Urine pregnancy test was done, which was also negative. We did a troponin because she was complaining of chest pain, which was negative. EKG showed normal sinus rhythm with no ischemic changes. We also did a chest X-ray, which showed no acute cardiopulmonary findings, and 2 sets of blood cultures were collected. Any thoughts on the patient disposition at this point now?
What would you guys have done? Admit the patient, do more workup, discharge the patient. There's no right or wrong. We're just trying. Okay, yes, RCRP, that's a good point, even though they're not very specific, but she has fever. We don't know where the neck pain is coming from. We want to see if there's like infection, inflammation. admit from workup. I think honestly that probably she would have needed some imaging at this point because she has a fever and we don't know what's happening. Okay. And yeah, she also has thrombocytopenia, and I mean, she has a fever, and yeah, osteomyelitis is definitely the differential. I think there's some of the differential diagnoses here that can be very, very, severe and kind of dangerous. But I don't know what happened, Neha.
Okay. So this patient was given pain management in the ED, was given 2 boluses of fluid, and since she felt better, she was actually discharged home with pain medication.
I think we are in disagreement, but I don't know. Okay, tell us more.
Okay. So the patient goes back home and the blood culture results come back, which shows MSSA. Hence, the patient was immediately called back and recalled back to the ED. This time, patient is now called back to the ED on Feb 5th, which is the encounter 3. She continues to have shooting pain associated with tingling in the left arm, which is unchanged from before. Patient reports that the pain is worse with movement now, which was also the case before. She said that while she was at home, she had 2 other episodes of fever of 100.4, but no chills and sweats. And in that encounter, at that point, she was not febrile. And she continues to have right lower back pain, which is still not radiating anywhere. Review of system-wise, it's positive for left-sided neck pain radiating to left arm, numbness and tingling in the left arm, and right lower back pain. And the other negatives are still the same. She's not febrile anymore, no chills, night sweats, or weight loss, or still does not have any bowel or bladder incontinence. And chest pain is also resolved, and no shortness of breath and abdominal pain. Physical examination wise, pretty much unchanged from before now that, I mean, she's not febrile anymore. Tachycardia is slightly improved, musculoskeletal wise, pretty much the same as before, still continues to have range of movement issues, tender to palpation on the left paracervical and right paralumbar area, and reproducible right lower back pain with ipsilateral and contralateral state leg tests. So nothing has changed from the past. So just to summarize on what happened, because a lot was happening with her, she first comes on 1st of Feb to the ED complaining of left-sided neck pain radiating to the left upper arm, was thought to be musculoskeletal, given pain management and sent home. She comes back to the ED on 3rd Feb, presenting with persistent neck pain, now with left upper extremity tingling, with fever and tachycardia, was given IV fluids, analgesia, discharged home, and blood cultures were drawn during that visit. Blood cultures come back, and on Feb 5th, she is found to have MSSA, is contacted back to the hospital, continues to have neck pain radiating to the left arm with tingling sensation, fever and chest pain has now resolved.
And then she's asking if they did a UTOX.
They did a UTOX, it was negative.
Okay. So I know it's a lot of information, but we can put them together. Who wants to try to piece it together? We do it together. And Neha, maybe you can go back to the prior slide so that we can help ourselves because it's a little bit long. So let's try. Someone volunteer themselves. Come on. It's only between us. There's no one here judging us. Come on. Omar, I see you. Do you want to try?
Yeah. So a middle-aged obese female with history of depression and anxiety, presenting with acute left neck pain radiating to the left arm and associated with fevers and chest pain, presented to the ED. Her physical exam was significant for left neck pain on palpation, and her blood cultures grew Staph aureus on the 5th day of her representation.
Perfect. I think you put together a lot of important things. You said that she's obese, that she had this acute neck pain, because for neck pain, acute, subacute and chronic is like, acute 6 weeks, subacute 6 weeks to 6 months, and chronic is more than 6 months. So that's an acute neck pain. And then you mentioned that there's a radiation, so there's like some radiculopathy. So we can also say that there's radiculopathy since we just divided the pain in musculoskeletal radiculopathy, and you said that as well. And now coming back with, persistent neck pain, now with new back pain and the MSSA bacteremia. So I think that's all the important information here.
I was just gonna make an observation. I found it interesting that she had a low-grade fever and they did blood cultures. And
And
nothing further, and she was sent home. I just thought
Right.
that
I thought
an
the
interesting
same.
observation, but it's all like retrospective. I just, was just commenting on that.
Yeah, no, I agree. I think it was weird because they acknowledged that she had a fever to send the blood cultures, but it was weird to me that they didn't do any imaging. Like
Or even antibacterials. It's like, it's interesting. They still let her go.
yeah, maybe because she was young, like 49. I mean, I guess it's young. I don't know if that's, I don't know. Yeah, I thought the same. It's weird. Cojonea, sorry.
Our problem representation wise, again, middle-aged female with past medical history of anxiety, depression, MVP, presents with acute onset neck pain requiring multiple ED visits with progressive symptoms of fever, numbness in the left arm and right lower back pain, found to have MSSA bacteremia and is now admitted for further workup. So we did admit her and do labs on her. Her white count is still normal. As you can see, we did an infective workup as well. We did her HIV test, which was negative. Hep C was negative. A hemoglobin A1C was done, which was 5.3. As someone suggested earlier regarding ESR and CRP, we did it. These are non-specific markers, but are very usually in any inflammation if they go up. So ESR was elevated, CRP was also elevated. And there is a minimal elevation in AST to 52. That probably is in the setting of the fact that she has been drinking about a pint of alcohol daily for about 5 years now. We also did a repeat UA, which was negative. Urine pregnancy test was repeated again, which was negative. We did a VBG, which showed a lactate still of 2.2. Other testing wise, we did a chest X-ray, we did a repeat chest X-ray, which again showed no acute cardiopulmonary findings. We did an ultrasound for her, which shows increased hepatic echogenicity, likely representing hepatic steatosis. Cholelithiasis was also found with no cholecystitis. We also did an echo on her, which showed an ejection fraction of 55 to 60% with no valvular abnormalities. Okay. So hospital course wise, now she's admitted on the 5th. On 5th night, she goes back to sleep without any difficulty, but she gets up on the morning of 6th with reporting that she was unable to move any of her extremities on waking up. The night before, she had no issues at all. She reported paresthesia in her arms and toes bilaterally. On examination, had 0/5 strength throughout, except for minimal 1/5 movement in the left foot, and occasional 1 to 2/5 movement in her left hand grip. A bedside bladder ultrasound was done, which showed 1 liter urine in the bladder, but the patient endorsed feeling nothing of, she had no feeling of bladder fullness. And a stat MRI was ordered in that case, and neurology and neurosurgery was contacted. Any thoughts on what would the MRI show at this point?
Okay, epidural abscess, absolutely, that's a great guess. And what are these symptoms telling us? Like actually these symptoms and signs, the fact that she cannot move her extremity, that her bladder has 1 liter of urine. Exactly, so that's compression on this, like we were saying before, so that's an emergency. So that's why you need now you need to start imaging. And as we were saying before, you do MRIs mostly more than CT. If you cannot have an MRI, you do the CT, but MRI will be your first choice with contrast.
Okay. So yeah, as you suggested, the MRI showed an epidural abscess extending from C1 to T2 and compression of the dorsal cord. If you see here, this is the abscess and it's compressing the dorsal cord. And another small epidural abscess was also seen in the posterior epidural L4 to L5 space. Okay. So a little about, I just briefly go over spinal epidural abscess. It's a rare infection of the epidural space located between the spinal dura mater and the vertebral periosteum. Epidemiology wise, the incidence has gone up in the past 2 to 3 decades. Initially, it was 0.2 to 1 case per 10,000 hospital admissions. It's gone up to 2.5 to 5.1 per 10,000 admission. Diagnosis is delayed in approximately 75% of the patients, and most patients, like our patient, presents multiple times to the ED or primary care setting for the complaint prior to diagnosis. Mortality in these patients is approximately 16%, while 15% of the survivors have permanent paresis or paralysis, and 27% have permanent neurological deficits. Risk factor wise, usually age demographic wise, age more than 65. However, now they're saying it's age more than 50. Any indwelling catheter, IV drug use, chronic alcoholic use, any comorbidities like HIV, which compromises the host immune system, diabetes, chronic renal failure, chronic liver failure, any systemic infection, or any surgical instrumentation of the spine, recent dental procedures Dr. Osori was asking earlier, and a recent endoscopy, and even an acupuncture could lead to an SEA. Clinical symptoms, usually neck pain or back pain is the most common and earliest symptom of SEA and is present in 75 to 100% of the patients. However, they're usually not caught at this point because we always think that this is probably musculoskeletal. A classic triad of fever, spine pain, and neurologic deficit are probably found in less than 30, like it's 13 to 37% of the patient. It's rare to find all three. And by the time you find all three, the patient has already progressed way too much. Fever is present in about 50% of the patients. However, lack of fever does not rule out an SEA. Neurologic deficits are also found about in 33% of the patient in earlier presentation, and it generally extends over 3 to 5 vertebrae. Differential diagnosis usually could include a disc or degenerative bone disease in which you have back pain and neurological findings. However, fever is usually atypical. Metastatic tumors also present in similar finding with back and focal neurologic deficit. Fever again is uncommon in this. Osteomyelitis, as someone suggested earlier, and vertebral discitis present in very, very similar findings. Even they have Staph aureus bacteremia. So it's for us, it's important to know Staph aureus bacteremia, fever, pain, and focal neurological deficit is not restricted to just SEA. Osteomyelitis presents almost in a similar manner. Lab testing is seldom helpful in SEA. ESR and CRP are usually elevated, but they are non-specific inflammatory markers. And leukocytosis is present only about 66% of the patient. Our patient had throughout her white counts were normal. Blood cultures are highly concordant with the spinal epidural abscess fluid culture results. Positive culture in patient complaining or neck or back pain should immediately raise a suspicion of spinal epidural abscess. And Staph aureus accounts for about 2/3 of all the spinal epidural abscess cases. And MRSA rates among Staph aureus isolates from SEA have ranged from 25 to 68%. Imaging modality wise, MRI of the entire spinal column with or without contrast is the imaging of choice in patients in which we suspect this. A whole spine imaging is recommended because abscess often span on multiple levels. As you see in our patient, the abscess went from the cervical region, thoracic, and was also a small abscess was also there in the lumbar region. And if MRI is not available, then CT myelogram is an alternate that can be used. Treatment is usually surgical decompression and drainage as soon as possible with systemic antibiotic therapy and empiric regimen of vancomycin, and a third of 4th generation cephalosporin is usually given as antibiotics. And the duration of antimicrobial therapy is usually 4 to 8 weeks. So in our patient on Feb 6, the patient underwent a C2 T3 laminectomy, evacuation of the epidural abscess with posterior fusion instrumentation. She initially did very well post-operatively and was actually even able to mobilize her extremities with physical therapy. However, since her blood cultures were not resolving and it continued to grow Staph aureus, we did a repeat MRI on the 14th, which showed a new epidural abscess now in the L3, L4, causing distortion of the thecal sac, and increase in the size of L4, L5 epidural abscess. On the 16th, she underwent another L3, L5 laminectomy and decompression. However, unfortunately, due to intraoperative course was complicated by shock, and she passed away on 18th from multi-organ failure. So, I mean, any questions so far?
I think what Lenise is saying. Yeah, I think like it's a number of, I think everyone's catching on just the workup from the beginning. I mean, even outpatient, new onset back pain, any type of musculoskeletal pain, like I do send, it's like a Poorman CRP ESR. Because persistent back pain sometimes gets missed too when it's a new thing. And, the thing is, what was her risk factor? Was it the chronic alcohol use? I missed about the thrombocytopenia, and I don't know because these white counts were sent, but what was the differential? Could have the CRP been done sooner? And then the persistent MRSA bacteremia, the hope is that ID was involved early. Because usually at this point, we sometimes do combination therapy when it's persistent, but we also are looking for another source. Like, if it doesn't clear, and this is why we always say, like, chase the blood cultures. Like, yes, get one blood culture, they're positive, but within 48 hours, get another one. I know that sometimes y'all get taught not to do them right away, but actually what you're trying to do is make sure that you're clearing the bacteremia right away, because if you delay the repeated blood culture, let's say like a week later, and the blood cultures are all positive, you're missing a week. And in that week, that bacteria, especially MRSA, can go somewhere else. And that's the problem. And so I don't know how far apart these repeated blood cultures were, and where combination therapy done. And, and also in the end, antibiotics can only do so much. And at some point, the things have to be drained. So I think some of the teaching point is just, the first step of what happened. And then the second step is just, following up on these blood cultures repeatedly. And even if it's within 48 hours, that's okay, because I know how hard they are to get. And hopefully in the future, that's not going to be the issue. With changing practice and other people drawing them. But within 48 hours, you should have a second blood culture, especially if they come back as 4 out of 4 bottles, all positive, is what I would say. And again, I think that's just one of the things I would just mention. Is it common? I don't know with this white cow, like I would like to see the differential a little bit more. It's not that common to have a normal white blood. So I would have seen, I think the fevers already tip you off. I don't know her normal white count, maybe for her that's high. And think about it from our patients, like AIDS patients, like a white count of 5 might be high for them if their T cells are less than 50. So I don't know what her normal was, but it's not that normal. It's not common to see a normal white count with an epidural abscess. But I'll kind of let Neha go ahead.
Joe was asking if there's relation to endocarditis and if TEE would be warranted. I mean, I think you would do at least a TTE when you have an MSS.
I mean, that's part of the workup. You're not even just looking at the spine, but you should look at the heart. You should look at anywhere that, like, especially, so there's MRSA, strep, not as common as your gram negatives, but your gram positives should always be considering workup, especially and this was in some institutions, the guidelines changed like more than 10 years ago, where you don't start for TTE. But if your suspicion is high, you should be doing a TE right away. And the good thing is cardiology is very good about, like, if the TTE is non-diagnostic, or if your suspicion is high, the next day they usually will do a TE. So there's no barriers to getting a TE here, but in some institutions, actually, they go straight to TE if your suspicion is high for endocarditis.
But then, like in this case, I wonder, since looks like she kept having bacteremia, even if they technically removed the abscess, like drained it, would you then do a TEE? Like, let's say that her
No, I'm hoping she got one done at some point in this hospital course, or maybe she was too unstable to even get it done. And sometimes we think, well, how is it going to change the management? Well, it does if something got seeded. Then it's CT surgery, but they might not even do anything. They might want to say continue antibiotics as is, but maybe if nothing got done, it was because she was unstable. But I would guess that she must have gotten one done, even a TT at some point, if not a TE. But yes, Neha, I know you have probably a lot more sites to go, so go ahead.
No, I agree, Dr. Sorry. She did undergo a TTE, which did not show any vegetation. And initially, they were not planning on doing a TEE because they thought the source has been resolved. However, when she wasn't getting better, TEE was planned. But by then, she was already started decompensating. And as you suggested, like, she was too unstable to get a TEE at that point. And white count wise, we do not have a baseline of a white count, because this time, like, she was coming to Sinai for the first time, but differential wise, it was neutrophil predominant. And in terms of a thrombocytopenia, it was eventually thought in the setting of a chronic alcohol use because she had coagulopathy, thrombocytopenia, her AST was also elevated. A possible differential of the thrombocytopenia, they also thought could be in the setting of her active infection. And ID was involved from the very beginning. The moment the patient got admitted, infectious disease was involved in the management of the patient. So overall, I just want to give you like a quick illness script for spinal epidural abscess. So epidemiology wise, it can actually occur at any age, but most prevalent in age more than 50. Risk factors are comorbidities like diabetes, HIV, chronic alcohol use, drug injection, any IV drug use, or any spinal abnormalities like trauma, degenerative process, or any spinal procedure. Microvise Staph aureus remains the most common organism causing SCA. However, gram-negative like E. coli and Pseudomonas can also be involved, and some rare are actinomyces, Mycobacterium, which is more so in developing countries, and fungi being Aspergillus and Candida. Pathophysiology-wise, bacteria gets access to the epidural tract either via contiguous spread, in which the cases are epidural osteomyelitis, like vertebral osteomyelitis, an infected pressure sore, or spinal procedure discitis, or it's a hematogenous spread secondary to a central venous catheter or endocarditis bacteremia. Clinical findings are, as I mentioned earlier, neuro-wise, there's nerve root pain, radiculopathy, motor weakness, sensory changes, bowel and bladder dysfunction. Systemic-wise, patient can have fever in about 50% of the patient cases with chills. And musculoskeletal-wise, there is back pain at the level of spine in about 70% of the patients. Classic triad of fever, back pain, and neurologic deficit is only present in about 13 to 30% of the cases. Elevated ESR and CRP are non-specific findings. However, they are elevated in most cases. And leukocytosis is only present in about 2/3 of the patients. Diagnosis is done by the abscess is diagnosed by an MRI. And for the organism, we usually do a drain. And blood culture is also highly correlates to the drain of the spinal epidural abscess. Differential includes vertebral osteomyelitis, discitis, spinal disc degenerative disease, or spinal tumor. And management includes surgery is the first line with antibiotics. We usually start with empiric antibiotics at vancomycin or ceftriaxone early. And surgery should be done as early as possible, ideally between 24 to 36 hours, because the more you delay the surgery, the less chances of patient recovering the neuro functions. So overall take-home points wise, again, classic triad is, we usually stick to classic triads, but it's very, very rarely found in 15% of the patient. Anytime a patient presents to the ED or a primary care setting with neck pain or back pain with either neurodeficit or fever should undergo emergent whole spine MRI. And patients who usually present with multiple times for the same or similar complaint should always be deemed high risk for any, like an SCA. All right. Any questions?
That was great. Thank you, Neha. Do you guys have any other questions, comments?
My last comment was just that, we get asked a lot about the bank levels. So I think right now, persistent MRSA bacteremia and someone that you're even worried about osteo, or you should really be thinking about troughs of 15 to 20. Most of the times we're doing now 10 to 15. So is this someone that you want to like really do your whole 15 milligrams per kilo, kind of really make sure that you're dosing appropriately, and maybe even Q12 versus Q8 for someone young, and check a bank random in the morning. It doesn't always have to be a trough. It's your first time to check the bank. You can always get a bank random in the morning. And then the ceftriaxone is actually your 2 grams, not the 1 gram. So for this case, you would start off with ceftriaxone 2 grams, and then you would push the vancomycin until you get more information. When she got admitted, you already knew that she had staph, so you want to maybe push the vanc more. I think it's retrospective, but it's just a sad case because she was showing up in the ED so many times, but yet was being missed. And I think the other thing that happens to all of us is that when someone's really young, they really are showing up like where the point is that you think that they're okay, but they really aren't. And I think that also kind of went against her because she was tachycardic febrile the second time around. And I think the second time around, retrospective again, I think she should have been admitted, at least further evaluated, I guess imaging even. And you don't know if that would have changed anything, but still, like that's what I would kind of go by. But that's I have my ID conference at 5, so I do have to log in and log out. Or log out, log in.
Joining the Thursday.
Okay, thank you guys. Bye. Bye.
Thank you all, guys, and have a nice evening, and see you next week. Bye.